Acha.
Good
Do
evening,
you
all
know
doctors.
how many people are there on the other participants link?
16.
I'll tell you, ma'am. Good evening, all
Yeah,
of you.
good
ma'am.
evening.
Hello,
Prasad,
good evening. Good evening.
Ganesh,
डॉक्टर शोभना नंबर पे ज्यादा ध्यान मत दीजिए.
Acha.
There are about
Acha, बहुत webinars
150
हैं.
logins, ma'am, as of now on the other participants link.
Huh?
There are about 150 logins on the
Acha.
other
वाह,
participants link.
गुड.
You have
And,
to just believe it, I suppose.
yeah,
Some
my
all of
entire
us have
team
to
and
log
even
in.
Dr. Stalin is also here, who would be available for
Would
us.
you like to
There are
start
only
from the
six.
your side first, or should we start from our side? How is it?
Yeah,
Ganesh
I'll
will
start
start
and then
first.
Dr. Stalin will introduce, ma'am. Then
Okay,
from
then
there, I think.
let's start. Please tell Dr. Stalin to start. It's
Good
6
evening, all
o'clock.
of you doctors, and welcome all of you, and thanks so much for accepting this invitation and being with us. And Dr. Stalin, you can take it forward with introduction of Dr.
Good evening, doctors. I welcome you all for this wonderful session, and I would like to introduce our speakers for the day. Yeah, 1 second.
Pratibha Singh has joined. Welcome, Dr.
Dr.
Pratibha.
Pratibha, good evening.
Hi.
Welcome.
Good evening, madam. Good evening.
गुड इवनिंग.
Madam. Good evening.
Hi, hi.
Good evening, everybody.
Hi.
Good evening, Dr. Pratibha.
Good evening, madam.
Yeah, good evening,
So
ma'am.
every
Good
other
evening,
day we
madam.
meet somewhere.
Hello.
Priya has not joined. Probably she must be busy with some meeting, I think. The dean also knows, so she's very busy.
Okay, okay.
Yeah, ma'am.
So
Thank you for this wonderful opportunity, ma'am. I would
Yes,
like
sir.
to thank Dr. Sanjaya Sharma and Dr. Shubha Saxena, madam, for organizing this meet today. And I would like to thank Dr. H.P. Patnaik sir and Dr. Archana madam for giving this opportunity. And I would like to welcome Dr. Patnaik sir for giving you an introduction speech on this webinar.
Me first or the host society
No,
first?
sir. We'll welcome you first.
Yeah,
Yes,
yeah.
I think
I
Jhansi
think I
and
should start now.
Makhanpur. Yes,
Yes.
Jhansi president first, followed
Ritu
by
and myself.
Makhanpur president. Yes, please go ahead.
Good
One
evening,
minute.
everyone. A very warm welcome to all assembled dignitaries, faculties, and the august audience from Jhansi and Kora Makhanpur societies to a very important webinar. There are 3 topics lined up which are relatively less discussed and pose a dilemma in our clinical practice. We are fortunate to have amongst us the Director Health Services Odisha from the land of Lord of Jagannath to bless our webinar. He is none other than our Dr. Hara Patnaik. We welcome you, sir. Our webinar is not complete without the blessings of Dr. Archana Verma, our dynamic, versatile, very versatile Vice President-elect, Dr. Archana Verma. We welcome you, madam.
Thank you. Thank you.
Now, I think I request Dr. Hara to please give a few words of blessing. He's the Vice President of FOXY 2009, President Indian Menopause Society 2015, Founder Secretary IMS Odisha Chapter, Governing Council Member ICOG 2011 to 14, National Corresponding Editor FOXY Journal 2012 to 2015. He was the Chairperson Geriatric Gynecological Committee FOXY 2004 to 2008.
Thank you, madam.
The President Association of Obs and Gynecologists of Odisha from 2015 to 2016. Ex-Special Secretary Health and Family Welfare and Director Health Services, Director Public Health Offices. And we are meeting him virtually now, but we have met him personally. We were very fortunate to witness his workshop with Dr. Mahapatra from Keyhole to No Hole, way down in 2012. He's a surgeon par excellence. We would like few words of blessings from you, sir. Dr. Hara Patnaik.
Madam, God only blesses. And he is the only person who can bless us. And I have always my good wishes. Today is a unique opportunity and academic program done by 2 societies, the Jhansi Obgyn Society and Kora Makhanpur Society. And we have Dr. Sanjay Sharma as President of Jhansi and Dr. Shubha Saxena Madam, which I just met now, and I have all best wishes. What Dr. Alka has told that I have been to Jhansi for a couple of times. The last time in 2011, when me and my teacher, Guru, Professor PC Mahapatra, we went together to Jhansi for a live operative workshop on vaginal hysterectomy, and what you see told that from keyhole to no hole surgery. And my colleague, my friend, Dr. Archana Verma, the dynamic lady of North, and she is very charming, smiling always, and ready to help. Done wonders as the chairman of Public Awareness Committee of Foxy, and now going to take charge as Vice President Foxy from the 2021. And we have a unique academic program. We have 3 great speakers today, and I am really very, very close to all 3 of them, Dr. Sobhna Mohan Das, Dr. Pratibha Singh, and Dr. Bhagyalakshmi Naik. It doyens in their field, and they are really doing wonders, and we are interested, we are keen to listen to their lectures today, and 3 extraordinarily brilliant person to chair the session. It is Dr. Alka Sethi again, as the chairing the first session of our Sobhna Mohandas, who will be speaking on ovarian cyst pathology and clinical correlation. Madam Alka, this is a great virtual platform, and you have given me a great opportunity. The Dr. Pratibha will be speaking on role of optimizers in PCO treatment, and the chairperson is none other than the dynamic lady from Jammu, Dr. Sudha Sarma, the incoming Secretary General of Indian Menopause Society, a great academician herself, a professor of Jammu Medical College. And the third speaker is very close to all of us, the Oncology Lady of India, the chairperson of Oncology Committee, Dr. Bhagyalakshmi Naik. She will be speaking on tumor markers. And the chairperson is Dr. Ritu Mittal, and from Secretary Kora Makhanpur Society. With these few words, I have got all the good wishes, my best wishes from the core of my heart to both Jhansi and Kora Makhanpur Society. And I hope these 3 dynamic academicians will deliver the good in a very nice way, and we are eager to listen to all of them. With these few words, I thank you all for giving me this opportunity, and thank you again. Thank you.
Thank you, sir.
Thank you, sir, for the kind words. I hand over the mic to Dr. Ritu Mittal, my good friend and companion from Kora Makhanpur Society. She's a senior consultant of Yashoda Hospital, Kaushambi, Ghaziabad. She's the secretary of CHEMOGS, and her areas of interest are high risk and antenatal obstetric care. She would introduce her president, Dr. Shubha Saxena, who will again introduce Dr. Archana Verma. So that's the sequence. Dr. Ritu, the floor is yours.
Thank you, Alka ma'am. I am privileged to be part of this webinar. I hand over the mic to my president, Shubha Saxena ma'am, who is a mentor and a guide to all of us in Kora Makhanpur. Shubha ma'am.
Thank you, Dr. Ritu. It's my pleasure to introduce Dr. Archana Verma, a person who everybody knows as a very dynamic and inspiring lady who has excellent organizational skills, par excellent, and has been successful in joining various gynae societies pan-India. She is an awardee of number of awards, and there are a lot of them in her kitties, like Abdul Kalam Award, organization. She's an organizing secretary of North Zone Yuva Foxy, World Women Health Organization, Wonder Foxian Award, and number of other awards. And she is really successful in bringing all these societies of this area under one umbrella. I welcome Dr. Archana Verma to carry forward this webinar.
Few words of blessings.
Thank you so much. And really respected Dr. Hara sir. It's so heartening to see, only sometimes the miracles do happen. And whenever we are thinking of the best moment, you get them. So what a great day to meet
Thank
Dr.
you.
Hara sir and Dr. Bhagya also. It is my Bhagya that two people from Orissa are here, and both of them are really very close to my heart. And they have Dr. Hara has been a kind of a mentor for me. He really supported, and how he and Dr. PC Mahapatra mentored me, I know. And this KMOX society, Dr. Hara, I tell you, this is a very new one, but people are really very dynamic in how good academic and cultural they are. It's really very good to see them. And Alka Sethi and Dr. Sanjaya from Jhansi. And this Jhansi, you know, everybody. I'm just thinking, Dr. Hara saying, I have been there so many times, and I was feeling, oh, I have never been to Jhansi, though I was asking Alka, I want to come to Jhansi, and but I just couldn't.
Yeah, most welcome.
And Dr. Sudha, and आप तो मुझसे दूर रहते हो, but
अरे नहीं बिल्कुल Dr. Archana, we've done so many programs here together.
Thank you. You did that CRPF program also very well. And what about today, the PCOS? We all know that it's such a complex endocrinological disorder, and to talk about it, and in all it affects in all the stages of life. And so many times the patient comes with the ultrasound report with the cyst and how they feel tremors, like, and asking, madam, ye kya cyst likha hai? Because when they Google it out and they listen to this. So, and the PCOS is the leading cause of ovulatory infertility also. Almost every second or third patient is having PCOS. So it's a good topic to discuss. And my best wishes to all of you for today. And all the three speakers are dynamic, and I'm dying to listen to them. And Dr. Shobna, I always say that she only motivated me to do all these webinars.
That's too much. That's too much.
शोभा बढ़ाइए आप, शोभना जी, Dr. Bhagya and प्रतिभा को बहुत सब लोग सपोर्ट करिएगा. This time she is going for elections, and we are with you, Pratibha.
Thank you, madam.
Thank you so much, Dr. Archana, for the words of blessings. We are honored to have three learned, eminent speakers for three important topics. Dr. Shobna Mohandas, Consultant Sun Medical Center, Thrissur, Kerala. She shall be speaking on clinical scenarios in ovarian cysts. So it is mostly clinical oriented. Dr. Pratibha Singh, Consultant Laparoscopic Surgeon and IVF Specialist, who shall be speaking on optimizers of PCO treatment. And Dr. Bhagya Lakshmi Nayak, Associate Professor of Department of Gynec Oncology, Cuttack, on tumor markers. All three are very important topics. And to chair these sessions, we have our President, Jammu Society, Dr. Sudha Sharma, and Dr. Ritu Mittal. She's the Secretary CHEMOX, as already been introduced. So I request Dr. Shobna Mohandas to start her deliberation. Brief introduction. She's the Vice President, IMS. She's an endoscopic surgeon from Thrissur, Kerala. She's a past Secretary General, Web and Quiz Committee, IMS, past South Zone Coordinator for Hysteroscopy Workshops, FOXY, past member Endocrinology and Food Drug Committees, past Vice President, IMA Thrissur, and she has been a guest speaker for more than 120 national lectures and editor of 2 textbooks in gynecology. Dr. Shobna, madam, the floor is all yours. We are waiting for your deliberation.
Thank you so much.
Hello. Yeah, madam, there's a request from the delegates that there is a background sound. So just switch it off if there is some sound is coming. Okay.
We'll mute everyone.
Yeah, just mute ourselves. Yeah.
Well, good evening, everybody. I thank Kora Makkanpur, Jhansi, our guest speakers, and the Shield Healthcare for organizing this program where I can share a few of my clinical vignettes with you on ovarian cysts. Because ovarian cysts have always been an enigma for all of us. And even if you say functional cysts, we really don't know what they are. So I thought I'll try to bring a little bit clarity on follicular cysts, corpus luteal cysts, and theca lutein cysts. Follicular cyst, why does it happen? Because a dominant follicle does not rupture, or the immature follicles don't reduce in size and the fluid collects, So it can be small or large, and it's actually dependent on gonadotropins. And normally everybody's doing ultrasound for something or the other, and that's how it's diagnosed. But sometimes they come with perunia, pelvic pain, tenesmus. And nowadays, a lot of people are on anticoagulants. They're all living with heart disease and stroke, and there can be bleeding, and we have had problems with these patients. Yes. And if at all you are forced to operate on them, and you find a thin wall cyst like this, then you can be happy that it's just follicular cyst, and if you leave a little bit of the cyst wall behind, doesn't matter, it cannot be a benign cyst. That's how you diagnose a functional from a benign cyst. The cyst wall is very thin. And sometimes what happens is, see that when it bursts, it will leave a amber colored clear watery fluid. All this will give you a diagnosis of a follicular cyst. So, and sometimes you think it's a twisted cyst, and then before you can diagnose it, it bursts. This patient had come with leg pain and severe pain in the abdomen. And I thought it is a twisted ovarian cyst, and see what it is. It is just a ruptured cyst. So why is a ruptured cyst giving leg pain? We have no idea. So it can come with vague things, and we are forced to operate on them. And when I put in a scope, I felt quite foolish because it was a ruptured cyst. But whatever it is, after the surgery, she did not have leg pain. So we get all these funny incidences, even with follicular cysts. And normally they will come with amenorrhea. You're wondering whether she's pregnant or whether she has ovarian cyst. And when you do a scan, you will find a follicular cyst. Most of them will disappear, but if it doesn't, you have to think of benign cyst. And OC pills, although Cochrane review has done an RCT and said OC pills or no OC pills, it's the same thing. It will disappear. But since it is gonadotropin dependent, it makes sense to think that OC pills will help. That does make sense. Corpus luteal cysts now are not as simple, Although it's also functional, it can really give you trouble in your practice because it happens because of capillaries invading the corpus luteum and bleeding into the corpus luteum. There is a clot inside the cyst. Normally, it's asymptomatic, but it can cause real massive intraperitoneal hemorrhage, and the bleeding will occur in the last half because the corpus luteum is in the last half. And it generally has a smooth surface, and when you do when you have to do a laparoscopy, you will find that the clot will just come out up like that, like you can see in this, and that's how you diagnose. And this is you can have hemorrhage in the peritoneum. Just see that cyst wall. It's not as thin as in the follicular cyst, and it will come out just like that. It will just pop off in your hand. That is how a corpus luteum cyst comes out. So this is a problem because it will come on ultrasound as complex cyst. And then you are wondering, what is a complex cyst? Is it blood? Is it endometrioma? Is it cancer? What it is? And then you look at those fibrins, the strands between, if those strands are going from one end to the other, it is cancer. But if it is fibrin strand, it won't go from one end to the other. But sometimes, see, you will have the strands going from one end to the other also, and still it is not a tumor. Here you take the help of color Doppler. If it is going all around the ovary, then it can be corpus luteal cyst. And there can be crenated granular walls. So all these ultrasound features will sometimes, make you operate on the patient. And you have to have a DD of ectopic pregnancy, ruptured endometrioma, or adnexal torsion. You see, one patient had come to me with a missed period, HCG is just 50, and she's come with acute abdominal pain, and her uterus has got just one fibroid. And ultrasound is showing a lot of query blood in the pelvis. Now, what to do? HCG is only 50. So it can't be ectopic. We can't say what it is. And the left ovary is enlarged. And this is what I found. There is a lot of amber colored fluid, and it was coming out from a punctum in the corpus luteum. And how so much of fluid came, we really don't know. But it was coming from a punctum on that ovary. And I tried to look into the tube. I tried to look everywhere and to see that punctum. That is from where all the fluid was coming. I was scared if there is an ectopic inside, So I looked into the tube, I looked into ovary, and it is just coming from that punctum. This patient has gone on to term. And why the pain came? The pain came because probably the red degeneration of the fibroid in the uterus. And she would come with severe pain, and you would think, what is happening? So it was not because of the fluid, but because of the fibroid that she, and so all these mimicking things happen with corpus luteal cyst. What about theca luteal cyst? Everybody is giving gonadotropin these days, and these can cause large, even 20 centimeter cysts on both the sides. 20-30 centimeter cysts can be there. I had a patient long back, she had come with a 3 months pregnancy, 10 centimeter cyst on one side, 5 centimeter cyst on the other side, both having multiloculated appearance with a small solid area. Oh, that small solid area, I got scared. Is it cancer? And she had nagging pain. So she was coming with pain, so I had to do something. But laparoscopy, I tried to separate, and it was really scary. So the point is, you should not do the mistake of doing a laparoscopy, whatever it is, because they will go off on their own. And when you try to do a laparoscopy or open surgery, there can be massive hemorrhage when you try to do it. So if you're, and the solid area that I saw in that laparoscopy finding was fat. How stupid that can be. It was just fat inside the theca luteal cyst. So it can be really misdiagnosed. Even if at the time of section you're seeing a theca luteal cyst, no attempt should be made to drain or puncture the multicyst because of possibility of hemorrhage. Of course, if you're a bold surgeon, you can attempt it because the patient is going to blame you if you don't do anything. But you take your call on that. And sometimes bleeding can be difficult to control. I have heard of another surgeon chopping off the ovary because he could not control the ovary, control the bleeding. So you have to be prepared. But I'm just telling you, theca luteal cyst, although functional, can also give you headaches. Epithelial, now you go on to epithelial tumors, serous, mucinous, endometrioid, Brenner, etc. Serous is simple, clear fluid will be there, thin wall, just like a functional, it will be there, but it will last beyond 8 weeks. And even if you see excrescence in the inside the cyst, you are not supposed to remove the ovary. You are supposed to only do a cystectomy. I had a patient with borderline tumor once, and then I had to go back in and do the hysterectomy. But even then, unless the patient is postmenopausal, you do not have to remove the ovary in these cases, because I've removed many cases with just excrescences, and they have gone on and on for so many years. You don't have to really remove the ovary just because you see a small cauliflower excrescence anywhere. What about mucinous cystadenomas? As against the serous, instead of clear, you will have those, that echogenicity there in the middle. And if you leave it alone, it will go on like this. This 1980 ka picture this is, and it can go to this big size. What about 2009? In here, they have put a picture like this on internet, 30 centimeter ovarian tumor. They have removed, and they have waited till that. In these cases, you don't have to really open. You can just puncture it, release the fluid, and then go in laparoscopically and remove the tumor. I know most of you will be raising your eyebrows when I tell you, because you're worried about pseudomyxoma peritonei. But 2015 reports have shown that intraoperative rupture of benign mucinous cystadenoma does not increase its recurrence. And laparoscopic removal, even in recurrent cases, is being reported. So it's not really a scary thing to do. What about benign germ cell tumor? All that fat and teeth and hair can give you bright echoes and sharp acoustic shadows. And that can be, it's a tricky thing. Unless you look for dermoid on ultrasound, you won't find a dermoid. It will come with a positive pregnancy test, and you will think it is a ectopic pregnancy. So these are the tricky situations. And when you're doing a dermoid, all I can tell you is, however experienced you are, at least for me, most of the time towards the end of my cystectomy, I do invariably lead to a rupture in the cyst. I'm honestly telling you this. You have to just put it into an endo bag and remove it. See there, this is almost the end of the cystectomy, and you can see that the wall is thin in some area. That it can happen even in open surgery. So it's not that only laparoscopic surgeons are guilty of this. But the point is, you should not let the hair into it. And if you have the hair inside, you have to take it out and go on washing till that yellow thing, that oily look of the water goes off. Till that oily water goes off for half an hour, you have to go on washing. That is the trick. And they will deliver afterwards. I have many patients who have delivered afterwards. And normally they don't recur. I have not seen recurrences from other surgeons either coming to me. So this is something that patients have to be told all this, because then they get scared. What will happen to my girl? Will she deliver? And will it come back again? These are common questions asked, and in literature will say all these things happen. But let me tell you, clinically, it hardly ever happens, and they do deliver normally. And now, another thing is torsion. Torsion can happen at first, the veins will be gone, then the lymphatics will go, and then finally the artery will go, leading to necrosis. If it comes early, well and good, you can actually save the ovary, and this is how it will come. And it's all white, and you just have to untort it, and if possible, do a cystectomy, because it's not always a functional cyst. Sometimes it can be a para-ovarian cyst, sometimes it can be a benign ovarian tumor. So as far as possible, we can do a cystectomy, because you don't know if it is a tumor and not a functional one. But look at this patient. She was a schoolgirl who had come with a twisted ovarian cyst on right side. I had done a cystectomy. She had a recurrence, and another gynecologist knocked it off. Third time she had a recurrence after 1 year, and she had this picture on the ultrasound, on the laparoscopy. So even if you have a picture like this, or even the first time if you have a picture like this, never remove the ovary, because when you untort it, it will become white, as you can see in this picture. And then after the whole thing was over, she went into menopause sort of, she didn't get her periods and FSH was high. So I got so scared, After 4 months, she rang me up and said, "Doctor, I got my periods." And after 1 year, she said, "Now come on, do something for me." I sent her to an IVF specialist. There was only that much ovary is only left. That little papery little ovary. Can you see that? That's the only thing that is left. And I was wondering what will happen, but she has 2 normal deliveries after this. The ovary picks up however little you leave. Therefore, the message of the day is, however bad your ovary is, conservative laparoscopic detorsion is possible, and it does not have any short-term or long-term associated morbidity. Another tricky thing is ovarian abscess, which is collection of pus. Of course, all of us know how to differentiate it. On ultrasound, you'll see a 4 centimeters. Cervical movement tenderness, fornix tenderness, high count, fever. Look for it. We gynecologists may not look for it when they come with their ovarian cyst, but look for it and you will find it. See, this is an ovarian cyst was going on from rounds of gynecologists. 4 centimeters cyst, pain is not going off. By the time she came to me, she had fever. And then by the time, so much of addition is there. If you just touch the intestine and also it will burst. That much it is, bad. So you should not wait till then if possible and see that pus draining out. So the point is, whenever you have a patient like this, you have to diagnose it so that you can put in your scope. And if you diagnose it early, in fact, you can just admit her, give antibiotic, and there might be improvement. You don't have to open also. But if there is no improvement, you can even put a drain inside the abscess. Hopefully, there's no intestine there. And if that also doesn't work, then only you have to go in surgically. But these things are tricky things that can really come in your practice and, trouble you, saying corpus luteal hemorrhage, endometrioma, simple cyst, and you get foxed with these things. And another thing is, whenever you have an ovarian system with a high CA125, in our country, TB. Even in a laparoscope, it will look as though it is stage 4 cancer. It is not stage 4 cancer. It is florid tuberculosis. And when you have a raised CA125, you think it is cancer. So you have to have this in mind. Another thing which I wanted to talk today about is peritoneal inclusion cysts, which are not really ovarian cysts. They are collections of peritoneal fluid trapped in adhesions caused by previous pelvic surgery, PID, or endometriosis. And then this collection will be there. You do a surgery and within 4 months, patient will come say, "I've got another cyst in my pelvis." That is not a cyst. It's actually collection of fluid. But if it comes with severe pain, you have a problem. You can't do anything but open the patient. And in laparoscopy, see, I'm trying to look and I can't find any place without intestine. I'm looking for, dying to find a place without intestine. I'm only in the center, little whitish area is there. Can you see that? That whitish area in the center. And at that whitish area, I opened and see, this is what I found. There is no cyst. It's just one hole between all the adhesions. And it's very tricky to open this post-cystectomy cyst. You can end up with adhesions. You can end up in puncturing the intestine. So properitoneal cysts are really a problem and the patients will blame you, but you should know about this entity. If they are coming without pain, just manage them conservatively. If they are coming with pain, yes, you may have to release it, but be careful, counsel them properly. That is there. Now, para-ovarian cysts are also there, which can also masquerade as ovarian cyst. And if it's as simple as this, a twisted ovary, you think it is ovarian cyst, and it turns out to be para-ovarian cyst, great. Patients, patients' mothers are happy, and because the ovary is spared and her ovarian function won't be lost. First thing when you go to the theater, they will ask is, will my girl's ovary go? And then you say, I'm not sure, little bit may go, but you can get married. There are people getting pregnant. All this dialogue doesn't have to be told if there is a para-ovarian cyst. Man, let me tell you, para-ovarian cyst can be really large, just almost up to the 10 millimeter port disease, but it is easy to remove it. Unlike an ovarian cyst, the peritoneum around a para-ovarian cyst is very easy to cut with a scissors. Whereas ovarian cyst, the differentiation between the ovarian cyst wall and the ovarian wall is going to be difficult. Here you can easily it just goes off with your scissors, however big it is, and you can puncture it and take it out, because generally it's not like, you don't even have to get scared of mucinous material. And surgeons will chop it off. The tube will be plastered around it. It won't be look like a, see, now the tube can be seen. When you separate it a little bit, then the tube will be shown. Otherwise, it will be shown as a flattened thing and you will end up cutting it. So you have to be careful. Now we go to ovarian cyst in pregnancy. It is indicated in acute cases, but in chronic cases, you should do surgery only in second trimester if you are convinced it is a tumor. And not in first trimester, because corpus luteal deficiency will be there. Last trimester is going to be difficult. Laparoscopy is feasible in all the 20 whatever cases I've done. They have all delivered normally. But take precautions to put in a nasogastric tube, put a supraumbilical port, and if possible, they do quite well with all this. It's easily possible to do a laparoscopy in ovarian cyst in pregnancy. Remnant syndrome. Some ovarian tissue, unfortunately, can be left behind even after oophorectomy, and they come with nagging pain. They go from pillar to post. I had a patient, 1 or 2 patients, some called me up on phone, some gynecologists called me up on phone, and they said they have got nagging pain. What I do is I give OC pills, and whatever cyst is there, it goes off. Sometimes they say you give clomiphene citrate, enlarge the cyst and try to remove it laparoscopically. But believe me, when you go in back with the laparoscope, it's not easy to find this ovarian tissue. It is hidden somewhere, and dissecting is not going to be easy. Best thing is I give OC pills and it goes off, They will come with dyspareunia, but it can be a nagging problem. That is there. And so now to give you a plan of what to do with benign cysts, I think everybody knows all this. If it is premenopausal, less than 3, postmenopausal, less than 5, it's a normal anatomic finding. Nothing to do. But less than 5 in premenopausal, 5 to 7 in a postmenopausal. Less than 5 in premenopausal, you can leave it alone. But postmenopausal, you have to do a CA-120. And not that it's very good. Dr. Bhagyalakshmi will give more about that. But you have to repeat your ultrasound after 6 weeks. 5 to 7 in premenopausal, you again have to do the same as that of postmenopausal, less than 5. After 7, it's generally you have to do either an MRI if you're not contemplating surgical evaluation, or straight away do a surgical evaluation. It's not mandatory to do an MRI before a surgical evaluation. That's what I want to tell you. And the same thing with the hemorrhagic cyst, almost the same. But remember that early postmenopausal and late postmenopausal is different. If the same things come in late postmenopause, you tend to do surgery more often. And whenever it is a postmenopausal patient, better not to leave the ovary behind. Always remove the ovary. When at a younger age, I told you, we normally do only a cystectomy. And endometrioma, these days we are giving just and trying and repeating and everything. But large endometriomas, you have to operate, because they are also going to endometrioid tumors. The oncologist will tell you better. Mature cystic teratoma, if not surgically removed, then you have to do early TVS. I don't know how much you can agree with that. So finally, every effort should be taken to determine if the pathology has borderline malignancy, but quite often it is only on histopathology that it is possible to have a final diagnosis. Follow-up of these cases should be more diligent in the postmenopausal patients. even if the cyst appears benign. You have to keep on following. That's very scary for the patient to ask them to come for scan again and again. Possibility of torsion of ovary or ovarian abscess may require special diagnostic, and you have to think of it. And you have to do immediate surgery in selected cases. One patient, you think of torsion ovary, and it was actually a ureteric colic. Even after the surgery, she had the same colic and I had to give medicines and it went off. But when they come with colic, you can't do anything now, and you have a cyst and a colic, you think of torsion. That is there. With that, I finished 20 minutes and I'm on time. So thank you so much for the patient listening.
Thank you, Dr. Shobna, for the wonderful talk. Excellent videos and very important case scenarios you've discussed, which will be really beneficial to our audience in our day-to-day practice. You've given the complete classification, practical tips, and very important discussions you've given. So it was really a wonderful talk, and the videos were really awesome. Especially when you see it live, then you know that if you land up in such a problem, what will you do? So that visual impression.
All of us face this, but I just gave a collection. That's all. Thank you.
It was very nice.
Thank you.
Nice
Thank you,
presentation.
Thank you,
and nice talk.
Thank you, ma'am.
Invite Dr. Pratibha Singh, the famous laparoscopist and IVF specialist from Bhagalpur, to deliver the talk on PCOS, for which I call upon Dr. Sudha Sharma. She's a former professor, Department of Obs and Gynae, Government Medical College, Jammu. She is member of the Managing Committee, PCOS Society. She is the President, Jammu Obs and Gynae Society, Secretary General, elect IMS, Indian Menopause Society, President, Jammu Menopause Society. I request Madam to please chair the session of Dr. Pratibha. The floor is yours, Madam.
A very good evening to all of you. Thank you, Dr. Alka, for such kind introduction. And first of all, I thank Dr. Shobna for this invitation, and Jhansi and the other society, Makhanpur Society, for hosting this so interesting interactive session. And I have seen Dr. Shobna's passion for keeping the ovary there, and the same is with me. I have so many times discussion with my colleagues. They say, why have you so much of love with the ovary? I said, no, before you touch this ovary, think 10 times, because this is the one which, this is the femininity, which is the one which keeps us going. So that was a wonderful session. So coming on to another session, PCO, very common disease. We know that it's a complex heterogeneous disorder wherein we look at the situation from womb to tomb. That means it's an adult disease of fetal origin. While PCO management in routine clinical practice remains fragmented, that is between the general physicians and the gynecologists and the endocrinologists, and there is a significant knowledge gap. What's the role of optimizers in PCOS treatment? We have today a very, very learned, pleasant, and a vibrant faculty from Bhagalpur. Dr. Pratibha Singh. Dr. Pratibha is the director, multi-specialty hospital and IVF unit in Bhagalpur. Her special field is laparoscopy and IVF, with diploma in laparoscopy from Germany and IVF from Dubai. She has the honor of giving the first IVF baby of Eastern Bihar and Jharkhand. She is the founder secretary Bhagalpur Society also, and has organized many conferences and has presented various papers. She is the recipient of Health Excellence Samman and so many other Samman from the Bhagalpur OB-GYN Society very recently. So over to you, Dr. Pratibha, for your presentation.
Thank you, madam, for your kind introduction. Now, presenter, can I share my screen?
Yes. Yes.
Can you see my screen?
We can see your screen.
Yeah. So, respected chairpersons and my dear friends, a very good evening to all. First of all, I would like to thank Jhansi and Kora Makhanpur Obs-Gynae Society for giving me this opportunity. especially President Dr. Sanjay Sharma, Dr. Shubha Saxena, and Secretary Dr. Alka Sethi and Dr. Ritu Mittal. And my respectful regards to our guest of honor, Dr. H.P. Patnaik sir and Dr. Archana Verma, and my co-speakers, Dr. Shobna madam and Dr. Bhagyalakshmi Nayak madam. And my special regards to my chairperson, Dr. Sudha Sharma madam. So after a wonderful talk and the video by Dr. Shobna madam, I'll be talking on the role of optimizers in PCOS treatment. Now, polycystic ovarian syndrome is the most common endocrinopathy affecting women of childbearing age. And it is mainly because of the result of overproduction of androgen, which is mainly associated with insulin resistance. And it is one of the leading cause of female infertility, where the infertility is mainly anovulatory type, and the cases are almost more than 75%. And the Rotterdam criteria for diagnosing PCOS is the presence of these three criteria. Out of these three, if two are present, then that is labeled as PCOS, which include irregular ovulation, excess androgen, and polycystic ovaries on ultrasound. The common symptoms of PCOS other than infertility are menstrual disorders, which may produce in the form of oligomenorrhea or amenorrhea, or there is increased LH and FSH ratio, which will prevent follicular maturation, resulting into anovulation. There is also high levels of androgen hormone. So this will produce the signs of hyperandrogenemia, causing acne, acanthosis, nigricans, and androgen alopecia and hirsutism. And along with this, patient will have metabolic syndrome because these females have a tendency towards central obesity and other symptoms associated with insulin resistance like dyslipidemia, diabetes mellitus, and some cardiac problems, which is mainly comes as a late sequelae of PCOS. So the management of PCOS not only include the symptomatic treatment, but it also requires management of the long-term consequences that have clinical and psychological effects on women with PCOS. Both non-pharmacological and pharmacological management strategies are crucial in overall management because the three main characteristics, that is hyperandrogenism, oligoovulation, and insulin resistance, should be treated to provide improvement in all aspects. And out of this, the insulin resistance is a primary cause of PCOS. And this insulin resistance is independent of body fat. That is, you can see PCOS in both lean as well as in the obese patients. And the goal of the treatment is those who are obese, first and foremost, they have to reduce weight. So weight loss is the first goal of treatment, and then decrease hyperinsulinism, decrease hyperandrogenism, induce ovulation, prevent endometrial hyperplasia due to unopposed estrogen production, and also to prevent metabolic complication, which is as a late sequelae. So the first line of treatment include the management of insulin resistance and obesity, which can be done by lifestyle intervention through diet and physical activity. Because weight loss improves the it mainly normalizes the hyperandrogenemia, improves insulin sensitivity, menstrual functions, and hirsutism. And according to RCOG guidelines, the first line therapy for the management of PCOS is lifestyle modification, which include calorie restricted diet along with exercise for at least 6 months, and then you can go for the second line therapy. Now, second line therapy, you can use insulin sensitizers. It has been seen that these insulin sensitizers have quite good role in managing PCOS. Because these insulin sensitizers, they directly sensitize insulin receptors, thereby increasing the insulin sensitivity, decreasing insulin resistance. It also prevents neoglucogenesis, which improves the glucose utilization, thereby decreasing the glucose levels. Also, it increases hepatic synthesis of sex hormone binding globulin levels. So there is decrease in the free and circulating testosterone levels, thereby decreasing the signs of hyperandrogenemia. It restores menstruation, normal ovulation, and this will provide good quality oocyte and improves the pregnancy rate. Now, there are different treatment management of the PCOS, and it is mainly dependent on the symptoms. So if the patient wants to conceive, in those patients, the treatment of choice is the ovulating inducing drugs, and in this clomiphene citrate, and now after the reintroduction of letrozole becomes the first drug of choice for this treatment of conception. Now, if the patient has menstrual irregularities, then OC pills has to be given in the form of desogestrel, which can be used in combination with ethinyl estradiol. If patient has features of hyperandrogenism, then you have to use cyproterone acetate along with ethinyl estradiol. And if the patient is obese, then drosperinone can be added. But what we have seen that all these management with these drugs, it cannot treat all symptoms of PCOS. So of late, there is new concept and rationale of new line of treatment with many adjuvant drugs, which are playing important role in PCOS treatment. And the basis of this new drug use is that insulin resistance contribute to the oxidative stress, and which plays an important role in pathogenesis of PCOS. But still there are, and here comes the role of optimizers in PCOS treatment, but still many of these optimizers have not been approved by NICE and the ASRM guidelines. The first insulin sensitizers which came in the market was this metformin, and it was used in the PCOS patient for glucose lowering. Although it was once thought to be a wonder drug, but accumulating evidences on its efficacy have been not that convincing, and this is mainly because of its side effects, because it has to be used in a very higher doses. And there are only 3 recommendations to use metformin in PCOS patient, and that is in the PCOS diabetic women to prevent cardiovascular risk. Second, PCOS non-diabetic patient with fasting hyperglycemia with obesity. And third, in IVF PCOS patient, in order to reduce the incidence of ovarian hyperstimulation syndrome. It should not be used to regulate menstrual cycle or to treat hyperandrogenism or as a first line of treatment for infertility or second line treatment after CC failure. It should also not to be used in the non-diabetic PCOS pregnant patients in order to prevent risk of gestational diabetes or non-diabetic PCOS in order to lose weight or to treat dyslipidemia in PCOS women. Other drugs are these. So melatonin. It is mainly secreted during the dark hours by pineal gland and is free radical scavenger and broad spectrum antioxidant. Its presence in follicular fluid reduces oxidative stress, thereby helping in oocyte maturation, fertilization, embryo development with high pregnancy rate. Whereas N-acetylcysteine is a building block of protein, it improves insulin sensitivity and decreases androgen levels, and it also prevents follicular cohort atresia and also improves the quality of cervical mucus. Another optimizer is this alpha-calcidol, which is an analog of vitamin D, and it improves insulin secretions, and its deficiency is associated with metabolic risk factors in patients with PCOS. According to WHO criteria, more than 80% of healthy Indians are vitamin D deficient. Although the exact association of vitamin D and insulin resistance is not fully understood, but there are a lot of incidences that support the contribution of vitamin D deficiency to metabolic disturbances like insulin resistance, obesity, hypertension, and menstrual dysfunction in PCOS female. So vitamin D deficiency may result into hyperandrogenism, leading to hirsutism or acne. It also causes infertility, menstrual dysfunction due to insulin resistance, increases weight. So the supplementation of vitamin D in PCOS is beneficial to reduce the insulin resistance and associated metabolic effects. Another component is this chromium polynicotinate. This provides a biologically active form of chromium which is easily absorbed. It helps in the binding insulin to the cell membrane receptor site and thereby improving the insulin sensitivity. There are several studies which show that the supplement, it enhances the metabolic action of insulin and it lowers the risk factors of cardiovascular disease, especially in the obese patients. And it also shows to reduce insulin resistance and also helps to reduce cardiovascular diseases and type 2 diabetes. Usually, as the age advances, the dietary chromium absorption decreases. So the supplements containing 200 to 1000 micrograms per day has been found to improve blood glucose control. And there are numerous animal and human clinical trials have been done which demonstrate that this chromium polynicotinate is quite safe in human beings. Another is this L-methyl folate, which reduces homocysteine level and prevents cardiovascular risk factors associated with PCOS. And it also reduces the risk of miscarriage and infertility. Now, world over treatment is changing, and the emerging therapy is with this myoinstall, which is proving to be very helpful in managing overall symptoms of PCOS. It acts as a secondary messenger in follicular growth and oocyte maturation through calcium ion oscillation. So this myo or D-chiroinositol not only improves glucose control, but also the reproductive abnormalities associated with PCOS. So this myoinstall acts as a secondary messenger for insulin signals and also for the oscillation calcium ions. So it acts as an insulin mimetic action. And normally the deficiency of inositol decreases this phosphatidyl inositol 3 kinase activity, which is an enzyme which is required for glucose uptake. So when there is a deficiency of myoinstall, there is decrease in phosphatidyl inositol 3 kinase, which causes decrease in glucose uptake, causing hyperglycemia, hyperinsulinemia, insulin resistance, leading to PCOS. So we need production and activation of this phosphatidyl inositol 3 kinase for normal cell glucose metabolism. And inositol both produces and activates this PI3 kinase. And inositol acts as a precursor for this phosphatidyl inositol 3 kinase. As far as management with myoinstall is concerned in PCOD, the classification usually shows mild ovulatory type or severe anovulatory type. And for severe anovulatory type, this myoinstall is quite good for both lean as well as for the obese PCOS. Now the treatment with myoinstall for the lean PCOS, the dose required is around 4 grams of myoinstall daily. Whereas for the severe PCOS, where there is insulin resistance is very high, so the urinary clearance of dichloroinositol is 6 times more. So you need a right dose and right ratio. That is at 40:1 ratio is required, where myoinstall should be taken as 4 grams and dichloroinositol as 100 milligrams per day. This install is a dietary, it is present in the food supplements, and they are found in many foods like fruits and beans, and it was first found in India from bougainvillea leaves. It is also the highest content of install is mainly in the grapefruit and in the beans, almonds, and walnuts, whereas in green leafy vegetable, the content is slightly less. And this myoinstall is essential for normal reproductive function of the female. In about 88%, it restores a spontaneous menstrual cycle with 72 normal ovulatory activity, and 30% establishes normal ovarian rhythm. It also helps in treating hyperandrogenism by reducing testosterone level to 73% and increasing sex hormone binding globulin by 92%. It also reduces hyperinsulinemia by 65%, and the concentration of myoinstall in the ovarian follicular fluid acts as a secondary messenger for follicular growth and maturation. So it plays a key role in nuclear and cytoplasmic oocyte development, and the high levels of myoinstall ensures quality of oocyte by decreasing LH to FSH ratio, leading to increased pregnancy rate. Now this slide shows the embryo quality after treatment with myoinstall, and they found that there was higher number of embryo with grade 1 when myoinstall was given. So myoinstall improves sex hormone binding globulin, thereby regularizing the menses and ovulatory function, improving oocyte quality, and improving pregnancy outcome. Milestone is also vital for fertility. Now, this is the article in one of the human reproductive journal, which concludes that high concentration of milestone in the follicular fluid is a marker of good quality oocyte. Now, in the normal follicles, it is rich in milestone with a ratio of 100:1. That is, milestone is to D-chiroinstall is present in ratio of 100:1. Whereas in the PCOD ovaries, there is 500-fold reduction in milestone. So milestone has to be supplied from outside. So inadequate milestone to D-chiroinstall level lies at the root cause of PCOD. Now, genetic predisposition to milestone to D-chiroinstall deficiency following an environmental trigger initiate a cascade of self-sustaining event that culminates into signs and symptoms of PCOD like infertility, hirsutism, acne, alopecia, irregular menses, and weight gain. So it is only when myo-install with D-chiroinstall levels are brought back to the normal levels, the PCOD can be thoroughly managed. So once they are given in the ratio of 40:1, the androgen levels comes down, the menses becomes normal, and fertility is restored. Management of PCOS is quite challenging. This is mainly because the root cause remains unknown and we are only treating the symptoms. And sometimes when the infertility and hirsutism, they both cannot be treated together because oral contraceptive will block ovulation, whereas anti-androgen cannot be used in the pregnancy as it is teratogenic. So two management categories are required, either for a long-term maintenance or for the treatment of anovulatory infertility. But with this myo-install and D-chiroinstall, it can take care of the whole spectrum of symptoms of PCOS. The only precaution you have to take here is that it should be mainly BMI based. And also, and that is why the unsatisfactory results are quite frequent with myo-install to D-chiroinstall usage, because the dose formulation is not correct. So there are 4 pillars of PCOD management with myo-install to D-chiroinstall, which include dose, ratio, compliance, and the formulation. So dose should be with the optimal dose is 4 grams per day for myo-install, and the optimal ratio is 40:1, where myo-install to D-chiroinstall. And the compliance, the taste should be acceptable to the patient so that it has better efficacy. And the tablets and capsules have a lower absorption, so it can alter the efficacy. So powder forms are much better. Now, myo-install and D-chiroinstall together are more effective rather than myo-install alone, because myo-install regulates cellular glucose uptake and D-chiroinstall regulates utilization of the intercellular glucose into energy. And this synergistic effect is at the ratio of 40:1, which allows quicker normalization of the glucose metabolism. There are almost 90 clinical trials, and more than 39,000 papers are published on the role of myo-install to D-chiroinstall in the treatment of PCOD, which is quite convincing. Now, this is a randomized controlled trial which was done in 2007, where they have used the myo-install therapy and found the impact of ovarian function and metabolic factors in PCOS patients. In this, they have taken 92 PCOS patients, and in group A, they have given myo-install along with folic acid, and in group B, they have only given folic acid. And after 4-month study, they found that in group A had witnessed the significant improvement in ovarian function in terms of speed and frequency of ovulation, and also achieving normal ovarian rhythms. So it was quite significant. Secondly, In group A, there was significant improvement in metabolic parameters in terms of weight loss, LDL level, and HDL level. Now, this is another randomized control trial where they have used malonestol therapy 4 months prior to patient undergoing ART treatment. And in group A, they have used 4 grams of malonestol with the folic acid, and in group B, they have used only folic acid. And after 3 months, the patient underwent ART treatment, and they found that in group A, ART improved oocyte quality. There was increased pickup rate, there was increase in M2 oocyte formation, and there was very much decrease in the degenerated oocytes, and grade 1 embryos were almost 30%. And also there was significant lower use of the gonadotropins during IVF cycle, and there was a lower peak of E2 levels at HCG administration, and also there was significantly higher number of follicles with diameter of more than 15 millimeters. So this is mainly because PCOD is the commonest cause of anovulatory infertility, which is mainly characterized by increased production of androgen and estrogen. So malonestol and D-chiroinstol, it decreases testosterone levels and thereby increasing the insulin sensitivity. So it increases the ovulation, quality of oocyte, and number of oocyte. So this suggests that malonestol can be useful in the treatment of PCOS patient undergoing ovulation induction, both for its insulin sensitizing activity as well as for its oocyte maturation. So these are the level of evidence which include all these randomized control trials, and then prospective comparative studies, then case control studies, and all endorse that malonestol in 4 gram in the powder formulation is quite effective. Even the international expert also recommend the use of malonestol and D-chiroinstol in managing PCOS. Clinical data demonstrate efficacy of malonestol and D-chiroinstol in the treatment of PCOD, and this evidence are strongest for the dose of 4 grams per day. As it is a food supplement, install are perfectly safe in pregnancy. Its safety parameter is similar to that of vitamin B complex group because it is water soluble and excreted via urine. Now, as far as side effects are concerned, with 4 grams per day, no side effects are reported, and with higher doses, there are chances of nausea, flatulence, and loose stool. There is almost 40% increase in pregnancy with the use of malonestol, and out of this 90% pregnancy are the viable pregnancies. Again, the malonestol was compared with the other drugs used in PCOD, like for ovulating inducing drug, clomiphene citrate. So the pregnancy rate with malonestol was higher than that of CC, and the multiple pregnancy was almost nil with malonestol as compared to CC. So malonestol is a simple and safe treatment and can be used as a primary method of inducing ovulation in PCOS women. Then it was compared with metformin. So malonestol has a better tolerability and better patient compliance than metformin. When it was compared with OC pills, so normally OC pills are used to control menstrual irregularities and hyperandrogenism, but it does not improve the root cause of insulin resistance. Hence, it has no metabolic advantages. And secondly, it cannot be used to improve pregnancy rate. So this makes malonestol superior to OC pills.
So you're half an hour into your talk. Can you be?
Yeah, finished. Yeah, I'm just finishing. Malonestol install take to total care of symptoms. So it is quite safe, well tolerated in both obese and lean patient. And it is not only safe in pregnancy, but it also beneficial as it reduces the chances of neural tube defect and improves gestational diabetes. So to conclude, polycystic ovarian syndrome is a convergence of multi-system endocrine derangements, and the impairment in the insulin metabolism is a prominent feature of syndrome, and it appears to play a key pathogenetic role in participating in the cascade of other disorders associated with PCOS. But we have to understand here that no drug can replace the lifestyle modification, especially in the obese and overweight patient, where the 50% treatment is simply weight control. Even if the patient can lose 5 to 10 kgs of weight, it is enough for restoring normal fertility. And the recent study reports that these optimizers reduces hyperinsulinemia, reverse the endocrinopathy, and normalizes the endocrine, metabolic, and reproductive function, leading to resumption of menstrual cycle and ovulation. But most of these are not still being approved by NICE or ASRM guidelines, so we have to be careful with that. PCOS cannot cure, but the symptoms can be managed. So we have to manage by optimization of the lifestyle through diet and exercise to lose weight, regular metabolic screening to prevent long-term sequelae, proactive fertility planning at an early age, and the use of standard drugs. These optimizers are quite safe and simple and have shown efficacy against biochemical and clinical endpoints in PCOS management and merits further consideration. Thank you for patient hearing.
Thanks, Dr. Pratibha Singh, for this so very informative presentation. How beautifully you have covered this vast topic, including pathophysiology and treatment with recent molecules. Now, since we are doing these discussions in the mid of COVID-19 pandemic, I want to add few things. I learned when I searched the literature that there is an overlap between the common PCO features and identified risk factors for severe COVID-19. So from various observations, it is clear that the cardiac metabolic diseases, which are common in women with PCO, they exhibit overlap with risk factors, which predispose them to severe COVID-19. So the suggestion is that these PCO patients, they are potentially at high than expected risk if they are confronted with COVID-19 infection. So whenever we deal with these kind of patients who are having COVID-19, we have to look for the high risk factors which they have normally in PCO. So thank you so much.
Thank you, madam.
Thank you.
Dr. for such a nice lecture. To take the proceeding further, I call upon the chairperson, Dr. Ritu Mittal, to chair the third session on tumor markers. And as I have already introduced Dr. Ritu, a dear friend of mine, and she's a consultant at the Yashoda Hospital, Secretary Camogs. Her areas of interest are high risk and antenatal and obstetric care. Dr. Ritu Mittal, please carry forward.
Thank you, welcome, ma'am. We all know there are multiple tumor markers, and we always confuse which one to do, which one to delineate it as benign, malignant, and which one to follow up to see the treatment is working or not. To clear these doubts, we have the star among us, Dr. Bhaglakshmi Naik ma'am, who is an associate professor in the Department of Gynecology from Cuttack. She has many awards and written many in many journals. Bhaglakshmi Naik ma'am. Ma'am, you are mute. Ma'am, you are mute.
Sorry. Yeah. Thank you so much for having me here. Thank you, Dr. Ritu, Dr. Alka, Dr. Sudha, and of course, not to forget Dr. Shobana and the whole of Jhansi Society and the Kora Makkanpur Society. It's always a pleasure to be with all our close friends. So thank you again. So can I share my screen, please?
Yes, please.
Yes. So I think my screen is visible.
Yes,
very much.
Okay. So thank you so much, Dr. Ritu, for those kind words. So we go to a very important topic, tumor markers in gynec cancers. As you know that technology is advancing very fast, and these technical parts of having the tumor markers being accessible is now become a little problematic for all of us to manage the cases, because we don't have the whole knowledge about interpreting the results of the tumor markers, and so everything sometimes goes haywire. So I think at the end of my talk, I'll be able to impress on all of you that tumor marker is only a value and nothing else. So we have to use our minds to interpret what it really means. We have to add up so many things along with that. No tumor marker is truthful or correct. So let's go ahead. So just to define, tumor marker is a biochemical indicator which selectively produced by the neoplastic tissue and released into the blood and detected in blood or in other body fluids. It may be used to detect the presence of a tumor, monitor the progress of the disease, monitor the response to treatment, but we have to remember that it cannot be used as primary modality for diagnosis of tumors, which we really falter many times in our clinical practice. So they may be surface antigens, they may be cytoplasmic proteins, enzymes, hormones, they can be really anything. So criteria of an ideal tumor marker should be, it should be specific, it should be very sensitive, and at the same time, it should be cheaply available and easy to perform and reproduce. So we have three types of classes of tumor markers, but most of them would not fit into any of these. Class 1 is an antigen which is very unique to a neoplasm and not shared by other tumors of the same histological type. So then it's a very, very unique. So class 2 is an antigen expressed by many or most tumors of a specific histological type and of other histological types as well, but they are not expressed by normal adult tissue. And class 3 are antigens which are expressed by both cancer and normal adult tissue. So there will be many types which will be overlapping each other. So the common tumor markers which we use in a day-to-day is, the commonest is human chorionic gonadotropin. I think all of us use that. Alpha fetoprotein, CA125, that's a favorite. Everyone does it in and out. Any ovarian cyst, everyone advises a CA125. So a CA19.9, CEA, and so many others are there. We go about them one by one. So why it's necessary? Because tumor markers were first tried to explode because they wanted to diagnose ovarian cancers early, because early diagnosis is the pillar of success. We can give a good survival. But so tumor markers were used. But at the same time, let me tell you, not any tumor marker is very truthful or speaks the truth. Yes, that if a CA125 is raised, this is a cancer ovary. So there's nothing like that. We have again to use a judgment. So no tumor marker is specific, and we have to remember this. So let us come to the first tumor marker, HCG, which we most of us use. It's a secretory product of the trophoblastic cell. It cross-reacts with the LH. So, and is used for the follow-up of molar and GTN, and is also produced by some ovarian epithelial tumors and mainly germ cell tumors. So it's selectively produced by the syncytial trophoblast. It's a glycoprotein. It has two fractions. One is the alpha and the beta. And there is immunological and biological similarity between alpha fraction and the pituitary gonadotropin. So the beta fraction of the HCG is specific. So whenever we are doing a test for the GTN or a follow-up of a molar, please advise a beta HCG, not HCG alone. And these are usually done by RIA and enzyme immunoassay. So a single tumor cell produces HCG around 5 into 10 to the power 5 to 5 into 10 to the power 4 international units per 24 hours. If a patient excretes 106 IU of HCG in 24 hours, that means she has around 1000 viable tumor cells. And normally also our gonads produce around 4 international units in 24 hours. So beta HCG is never normal. It's around 5 to 10 varying according to the laboratory. So when you are giving methotrexate treatment, the serum level of HCG is measured at weekly intervals to see whether it's coming down or it's plateauing or it's going up. The HCG regression curve serves as an indicator to determine the need for a second course of chemotherapy or when to stop, how long to give. A second course of chemotherapy is to administer under the following conditions. If HCG level plateaus for more than 3 consecutive weeks or begins to rise again, or if the HCG level doesn't decline by 1 log, that is, doesn't fall by 1/10 within 18 days of completion of the first course of treatment. So this is how beta HCG helps us to monitor the treatment. So during the second course of the chemotherapy, the dose of the methotrexate is kept unaltered if the patient response to the course of chemotherapy is adequate. If the response is inadequate or the fall is not as per we desire, the dose of the methotrexate can be increased from 1 milligram per kg to 1.5 milligram per kg. So, but the fall, there is a fall in the levels of the beta HCG, but it is not up to our expectation. Then you can increase the dose of methotrexate. But an adequate response is when serum level of HCG falls by 1 log, which I have already told, by 1/10. If the response to 2 consecutive courses of chemotherapy is inadequate, the patient is considered resistant, and you can change the chemotherapy from methotrexate to actinomycin D. Subsequently, the response to actinomycin D is again estimated by measuring the serum HCG level. And again, if the patient is resistant to actinomycin D, then of course we go over to other multi-drug regimen called Inaugural. So this is a simple case. She is NB, presented with severe vomiting for 1 month, had a history of MTP 1 month back. Her on clinical examination, the cervix looked violaceous, there was ballooning, the uterus was around 8 to 10 weeks. So tissue from the endocervix was sent for histopathology and showed some evidence of trophoblastic tissue. So we thought it could be some cervical pregnancy, and the beta HCG was sent, serum beta HCG, and it showed only 15. So we never ever thought that it could be a malignant gestational trophoblastic neoplasia. So the diagnosis was RPOC or cervical pregnancy or anything, or some kind of molar event which has led back some tissue. So ultrasound again showed similar things like a huge, the uterus was enlarged, there was inhomogeneous opacity inside the uterus, and there was ovarian cyst on the one side, of course both sides, and one was bigger than the other. X-ray chest was normal. So as she was a multiparous, surgery was done for her. But the post-operative period was very, very stormy. She had profuse vomiting, and the 5th post-op day, when I was taking the rounds, she called me and told me, "Madam, kuch chupta hai." And then I could see that she had developed this vaginal nodules on the 5th post-operative day with a beta HCG of only 15. So beta HCG was repeated, and again it was 123. But the histopathology tissue was choriocarcinoma, the cervix tissue was choriocarcinoma, and the right ovarian showed a mucinous cystadenoma. So low beta HCG can happen in choriocarcinoma. So please don't go with the values of HCG. Please use your clinical acumen for that. So when can this be possible? So when the tumor is very encapsulated, very when it is composed mainly of non-secretory elements, or the histological diagnosis may not be correct, or if there is cytotrophoblastic dominated GTD, or sometimes it's called a hook effect when the levels are very, very high, but the machine is not able to pick that up. So I think this is a condition which I think everyone will remember throughout their life, that we can have very low levels of beta HCG in spite of having a diagnosis of choriocarcinoma. But the other thing is also correct, that without a disease also sometimes the beta HCG may be raised. So this is called a phantom HCG. This is called a false positive. It is due to heterophile antibodies, and it's a non-progressive rise. The rise will be almost a constant, like around 2 figures. It hardly reaches 100. Urinary HCG will be negative because it is caused by heterophile antibodies, which are big antibodies, are not able to cross the nephrons and go to the urine, and common in peri and post-menopause with high LH levels, and usually in a single or double digit, and these are very readily suppressed with OCP. So we have to remember 2 things. We can have a very malignant disease with low levels, and sometimes we can have positive HCG without any disease. So coming to cervical cancer, we do not really use very commonly squamous cell carcinoma antigen, but studies have shown that the increased pre-treatment serum levels and failure of the levels to normalize at the completion of treatment are associated with a decreased progression-free survival. Chinese studies have also demonstrated that serum squamous cell carcinoma antigen levels is more reliable for evaluating response to neoadjuvant chemotherapy than MRI. Japanese study has recommended routine squamous cell carcinoma antigen monitoring following treatment, and the overall survival was higher when recurrence was predicted on the basis of tumor marker elevation than when diagnosed by other modalities. So coming to our favorite ovary, so these are the most common tumor markers that we use: ovary CA125, OVA1, HE4, CEA, inhibin. I think all of these are now available everywhere. So let's go case by case. So she is an 18-year-old lady staying in hostel, presented with history of irregular bleeding PV, 2 episodes and history of abdominal distension for 2 weeks. She had no features of hirsutism, no other significant history. On abdominal examination, she had a cystic mass equivalent to 22 weeks of pregnant uterus. There was no ascites. Ultrasound showed a 22 into 23 centimeter large multilocated cystic lesion occupying whole of the abdomen and pelvis. So at this juncture, I think we have to use our mind to select which tumor marker we have to use. We can't possibly tell her go and do whatever is available. So what tumor markers would you advise? So as she was a young woman, so these tumor markers was all done. That is LDH, AFP, and beta HCG. These are the most common. And CA125. CA19.9 was available, and someone has done this, but this is not at all important. So these are the 4 markers which are important because she had vascularity and had thick septa. So the surgery was done. and it was a borderline mucinous tumor. So here you can see, going back to a slide, that CA125, a little raise in the diagnosis is not very diagnostic of anything. So we have to keep in mind the imaging and the histopathology and the tumor markers together. So this was a case of a borderline mucinous tumor. So what are the conditions in which we can have a raised CA125? In a varied number of conditions, in non-malignant disorders, in non-pelvic mass associated disorders also we can have a raised CA125. We can have secondary pelvic involvement, lymphoma, pancreatic carcinoma. I think anything that irritates the peritoneum will have a raised CA125. And as Dr. Shobana has very clearly told, that CA125 is also raised in tuberculosis, which we have to keep in mind. That's a very important, because India is a country in which we get quite a number of cases of tuberculosis, and I'll show you one of these cases. And then coming to the ratio between CA125 and CEA. So many times we do both the tumor markers to guide us. So the CA125 to CEA ratio is now considered helpful in deciphering the site of the neoplastic origin. So if the ratio is greater than 25, it's generally consistent with the ovarian origin. Or if it's on the other side, we can also know that whether it is a serous ovarian cancer that we are dealing, or a mucinous, or it's of a mucinous differentiation. So I think if the CA125 is 25 times higher than CEA, it's a serous tumor. If otherwise, it could be a mucinous tumor in which both may be raised. So here you can see a mucinous tumor in which you can see the mucin exuding from the tumor. So HE4 is now emerged as a novel tumor marker for recurrence that is indicated for women with known ovarian cancer who have been treated. Glycoprotein, and the other very important thing is HE4 is an important marker in masses in premenopausal women, because as we know, CA125 can be raised in many cases of endometriosis, which is also very quite common. So we do a HE4 to differentiate masses from endometriotic masses from neoplastic masses. So HE4 is a good marker which you can do in premenopausal women to differentiate from endometriotic masses. So this is a case again, a 25 years old student, not married, sexually active. Ultrasound showed left adnexal cyst with multiple septations with few internal echoes, and she had a little pain. So we thought it was endometriosis. But the tumor markers were all normal. And so this was the finding. She had a paratubal cyst, maybe due to the PID. So this can also happen. So if the tumor markers are all maybe normal, that always points towards a benign pathology. So scoring system should be kept in mind. One is called the ROMA, which is risk of ovarian malignancy algorithm, which you have to fit in everything, CA125 and HE4, and that will give you a diagnosis. And ROCA, or the risk of ovarian cancer algorithm, used as a screening algorithm. It's a dynamic test. We have to take the levels of changes in the CA125, and it divides the lesion into low risk, intermediate risk, or high risk. So, and from that you can decide as to where to send the patient or to operate yourself. So RMI is whenever you see any ovarian tumor, I think you should do a RMI to diagnose whether it's a benign or a malignant condition. So 3 pre-surgical factors are taken. One is the serum CA125, menopausal state, ultrasound score. So from here we can see that tumor marker is not a definite thing. We have to add so many things along with that to reach at a diagnosis. So there is again currently not enough evidence to support the routine clinical use of other tumor markers such as HE4, CEA. So again, it all has to be very, very corroborative. As I have already told, no tumor marker speaks the truth. So this is again an 18-year-old with a vague pain abdomen for 1 week, irregular menstrual cycles, hypothyroid 1 year back, and taken treatment for 1 month and discontinued. On examination, she had a puffy look and had a leg edema, and her secondary sexual characters were all normal. There was a soft cystic mass in the lower abdomen about 18 weeks. So here you can see the cysts which are shown. The ultrasound showed bilateral cystic ovarian masses, and CT scan again confirmed the same thing. So what tumor markers would you advise in this case? Again, we have to think what should be done. She's a young girl. So all these were advised along with the TSH. So here we saw that other markers were normal, but the TSH was 153. The FP was slightly raised, and again, it was has no significance. Prolactin was raised because it was a hypothyroid case. So you can see that in hypothyroid, we can have huge ovarian cysts, and these cysts will surely disappear when the thyroid levels come come to normal, because TSH has a stimulatory effect on the ovaries, which leads to this cyst formation, and she was completely cured after being treated with L-toxin replacement. So 34 years, para 1 L1 lady presented with abdominal pain for 2 months, had 1 episode of severe pain and history of frequency of micturition and history of fever on and off for 6 months. MRI pelvis showed a large lobulated solid mass of 14 into 13 into 12 centimeters with areas of necrosis. And so here you can see what it's a huge mass and has variegated consistency with little tiny air pockets and mildly enlarged mesenteric lymph nodes. But mind it, she had a little history of fever. So of all the markers, everything was normal, only CA125 was raised. So with this finding, I think again you have to corroborate everything, and she went ahead with surgery. And the histopathology was torsion with infarction on the background of chronic abscess. Dr. Shobana has very nicely shown that ovarian abscess is also a possibility. So kindly keep all these things in mind. Don't go away with malignancy. Whenever CA125 becomes 40, everyone thinks it's ovarian cancer, and they really scare the patient off their nerves. So she is again, this is the, I think, most important and the very important and a difficult case which I have come across in my life and will never forget. She was only 21 years and para 1, had pain, abdomen, ascites. All the imaging were pointing towards malignancy. She had omental thickening. She had peritoneal nodules. CA125 was 5,689. I think with this large CA125 value, someone has taken up her for surgery, and on opening they saw it was full of nodules. The uterus was had some disease. The omentum had disease. The serosa on the tubes, everything had disease. So to her utter sadness, TH, BSO, and omentectomy was done for this patient, but unfortunately the post-op biopsy was tuberculosis. So very high values of CA125 can occur with tuberculosis, and tuberculosis is not very uncommon in a country like ours in India. So please don't go with high with the values of CA125. So this is again a case, 26 years old, para 1 L1 with BMI 27, presented with abdominal pain, had left adnexal mass of 10.5 into 7.2 into 7.4 with highly vascular with mixed echogenicity and mild ascites. Her CA125 was 419, LDH was 500. Please remember that LDH is a very non-specific marker and may be raised in so many other conditions other than even ovarian tumor. And beta HCG was normal, and the AFP was 15,000. I think AFP is a very subtle marker in ovarian tumor, and when raised points towards yolk sac tumor. So we have to be very careful with values of some tumor markers which really help us reach at a diagnosis, and some which will really confuse us. So we have to know what is the importance of the values of these tumor markers. So here you can see that it was a huge tumor, and the construction shows brain-like material, and the histopathology was yolk sac tumor. So the right ovary showed malignant germ cell yolk sac tumor, and the left ovary showed a small mature cystic teratoma. So without histopathology, only two tumor markers, one is the alpha fetoprotein and HCG, are sufficiently specific to establish a diagnosis of malignant ovarian germ cell tumor in a young non-pregnant woman with a pelvic mass on imaging. Mind you, HCG is a marker for GTN, so we don't need a histopathological diagnosis to diagnose a GTN. So HCG is a very specific marker, and similarly, alpha fetoprotein with a pelvic mass in a young girl is very, very corroborative with the yolk sac tumor. And similarly, LDH and CA125 are very, very non-specific biochemical markers in all kinds of ovarian tumors. So just to summarize, if it is a premenopausal simple cyst, then you really don't need to do any tumor markers. If she is an asymptomatic patient, if the tumor is less than 5 centimeters, please discharge her, just observe. If it is 5 to 7 centimeter, you can do an annual scan. If it is more than 7 centimeter, consider surgery. So the ultrasound, please ask for a good ultrasound. If it is a simple cyst, we really don't need to bother too much. If it is a complex cyst, and she is premenopausal, and if she is less than 40 years, we do a LDH, AFP, beta HCG, and we may add CA125 if she is more than 40 years. So now we can do the RMI. If it is less than 200, we think it's endometriosis, fibroid, or some other complexes. But if it is more than 200, we have to think of an oncology multidisciplinary team to take a decision about what surgery will be planned for her. Maybe we can keep a frozen section in hand while doing the surgery. So in postmenopausal ovarian cyst, we need to do a CA-125, a trans-abdominal and TB scan, and then come to the RMI. And if that RMI is 25 to 250, we can think of doing the surgery at a center where there may not be an oncology specialist, but in case it is something more than 250, I think it's better to refer the patient to an oncology center. Similarly, if it is a postmenopausal woman and the RMI is less than 25, simple cyst, unilateral less than 5 centimeter, CA-125 less than 30, we can do the TB scan and CA-125 every 4 months for 1 year. If there is no change or it has resolved, you can just discharge her. If it increases in size or becomes suspicious, we have to recalculate the RMI and then advise. Or if there is something else, we can consider surgery if it is not ovarian cyst. So then coming to the role of some tumor markers in endometrial cancer. Mean levels of CA-15.3 and CA-19.9 are found significantly higher in women who require adjuvant therapy, that is, who are higher stage endometrial cancers. And the levels of CA-19.9 are also predictive of deep myometrial invasion and cervical involvement, which are very high risk endometrial cancers and will need proper surgical staging and adjuvant treatment. CEA and AFP levels are inadequately able to predict any of the evaluated poor prognostic parameters and requirements for adjuvant treatment. So no serum tumor markers with high sensitivity and high specificity for endometrial cancer. CA-125 is used in clinical practice when extrauterine disease is suspected, and good correlation between serum CA-125 levels and the clinical stage of the disease has been shown. So it's 15% in stage 1, 33% in stage 2, 61% in stage 3, and 100% in stage 4 when the uterine disease has spread to extrauterine spaces, that is into the abdominal or the peritoneal cavity. So elevated levels of CA-125 significantly predicts extrauterine disease, tumors larger than 2 centimeter, invasion of the deep myometrial and LVSI. So I think whenever you come across a case of endometrial carcinoma, there is no harm in doing a CA-125, which will help you to reach at a diagnosis whether it's a more advanced disease or is a less advanced disease, which you can operate at your center. So tumor markers in gynecological cancer, we have to really understand which one speaks the truth. I think there is no real tumor marker which speaks the absolute truth. So we have to add up all the corroborative things. So it has to be a laboratory finding, that is the tumor marker value, the radiological finding, the clinical data, and of course we have to amalgamate everything in our mind, our brain, see the patient, see the clinical judgment is very, very important, and then come to a diagnosis whether it's a benign or a malignant lesion. So the summary is that please think of very common problems first and exclude more serious problems. We always jump to a serious problem first. So early diagnosis is the crux, because as we know that if we pick up a case early, I think we can give her a very good survival, because delay in diagnosis really reduces the survival rates, and mainly we may land up in medical legal issues. So be very careful to handle the tumor marker values and understand them and interpret them properly. So because high tumor marker levels may be deceptive, and they may sometimes be also low even with very advanced disease. Even coming to CA-125 with very advanced disease, we have also seen very low levels of CA-125. So they are very deceptive. Please treat them very carefully. And thank you very much for your patient hearing.
Thank you, Naik ma'am. It was a very interesting and detailed information about tumor markers, which we are always confused which one to choose and which one not to. Now I invite Dr. Ruhi, who is a senior consultant at BHL Hospital, Jhansi, to give a vote of thanks. Dr. Ruhi?
1 minute. Before that, is there any questions from the audience?
Ma'am, there is no questions in the chat box. I think in this, there is no question.
No, Dr. Alka wanted to show the presentation on COVID, I think.
Okay.
All the speakers were fantastic.
Thank you, Dr. Archana.
Thank you, madam, for staying till the end. I had given it to Mr. Ganesh. I don't know whether he's going to play.
Ganesh is there around?
Ma'am, I have the presentation, ma'am. Shall I flash it, ma'am?
Yeah,
It's,
yeah.
the last two
Because
slides, that is very important. After that,
I
we
just
can
saw
have
the
the
WhatsApp message just now, so I don't know. So I didn't know before this. Yeah.
sent by Dr. Bhaskar Pal and from Bengal Obstetric Society. I found it very useful. So
Okay,
I
let's
thought,
change.
yes, we should flash.
Yeah, next.
For the
Someone can
audience.
read it out. No, it will be nice if can please someone can read it out.
Okay, whenever we let our guard down, we are at risk. In other words, even though we think we are taking precautions, there are everyday situations where we become careless. Patients as well as colleagues must be considered as virus carriers. Pre-symptomatic and symptomatic colleagues spread infection. So interacting with colleagues with mask down can be dangerous. Spread also happens in non-patient care areas like break rooms, nursing stations, and cafeteria. Having lunch together involves not only lowering of mass but also conversations and prolonged exposure. Next. So, it's normally occurring where people were less alert. There were no infections in ICU or COVID wards. Patients with atypical symptoms and delayed diagnosis contributed to HCV infections. When more testing became available, there was less infection. That means the patients were identified early. HCV-W can get infected outside the workplace, that is 14%, even from family or community. But in 50% of cases, no source was identified. If you have symptoms of COVID, please isolate yourself. Usual symptoms are symptoms of flu and anosmia and diarrhea. Monitor SpO2. So all these representatives are sending us this pulse oximeters. Consult a COVID physician, especially if you have any comorbidity. It's a good idea to be tested around day 5 of the symptoms, not initially. If you get well in a couple of days and choose not to get tested, still monitor your SpO2 for 2 weeks. If you are symptomatic around 5, you must get tested. If you have any comorbidity like metabolic syndrome or COPD, get imaging of the test and bloods done around day 7 of the symptoms. Most complications happen in the second week, that is day 10 to 12. That is the most dangerous time, and early treatment reduces mortality and morbidity. Breathlessness or reappearance of fever or even SpO2 less than 95% or a drop in SpO2 by more than 4% after walking for 6 minutes. These are the warning some symptoms. That's the end of the slide. Thank you.
Yeah.
It's very scary, you know?
It's the need of the hour.
Yeah.
Dr. Farad, please carry on with the vote of thanks.
Yeah, ma'am. Yeah. Okay. A very good evening to all the dignitaries. It gives me eminent pleasure to thank to all the eminent stalwart speakers and all the participating delegates. First of all, I want to like to thank our guest of honors, Dr. Harra Patnaik sir and Dr. Archana Verma ma'am for showing their blessings and guidance. I'm thankful to the presidents of Foxy, Jhansi, and Foxy Committee, Kora Mangal Makhanpur. Yeah, Kora Makhanpur. Anja Sharma and Shobha Saxena for their initiatives and keenness for this webinar. I would like to thank our speakers, Dr. Shobhana Mohandas, Dr. Pratibha Singh, Dr. Bhagya Lakshmi for their wonderful lectures, case studies, and experiences. They were wonderful. I'm also thankful to our chairpersons, Dr. Sudha Sharma, President Jammu and Kashmir Obstetrics and Jammu Obstetrics and Gynae Society, Dr. Ritu Mittal, Secretary Foxy, Kora Makhanpur, and of course, our enthusiastic, charming Dr. Alka Sethi for her insight and initiatives. And last not the least, I would like to thank our Shield Organizers Connect, whole team of organizing session, and all of you for their maximum
out of session. I think all of you have enjoyed it and we gained the maximum out of it. Thank you.
Just a word about Dr. Ruhi. We can call her a Corona warrior because she is looking after the whole BHEL with so many patients and all her OPD. So we also wish her luck and stay safe. And everyone should take care of oneself. We are not practicing so much, but
we are.
But we have to say namaste to people who are doing so much of good work.
Good luck
Thank
to
you so
Dr.
much.
Ruhi.
Thank you, ma'am. Thank you.
The best, Dr. Ruhi.
Would Shield would like to say something? Stalin, Dr. Stalin,
yes,
or
ma'am.
somebody from Shield?
Yes, ma'am. So thank you, doctors. Thank you very much for your excellent and updated and informative sessions. Initially, I would like to thank Dr. Alka Sethi madam for taking the whole session in a wonderful way. And I would like to thank our guest of honors, Dr. Prasad Patnaik sir and Archana Verma madam for spending their precious time with us today. I would like to thank the other chairpersons, Dr. Sudha Sharma ma'am and Mittal madam for the today's session. A special thanks to Dr. Shobana madam for her amazing presentation with live videos. And I would like to thank Dr. Pratibha Singh madam for enlightening us with the recent molecules used in treatment of PCOD. And I would like to thank Dr. Baikalakshmi madam for a session on tumor marker with those clinical cases. Thank you for your time, ma'am. Thank you for your spending your precious time with us. And on behalf of Shield, I thank you once again for this wonderful webinar, ma'am. Thank you.
Ranjana Khanna is logged in. I can see her name. Madam, please put on your video. We can say hello to you, Dr. Ranjana.
Is the dean. Ranjana, yeah. Where is she? She's not showing herself. Maybe. Yeah. Anyway, it's nice to have her here. So we say goodbye after another.
Thank you, everyone. Thank you, everyone.
Thank you, Bhagalakshmi. So many cases you have collected. How much effort you have taken to get all those things. It really takes a lot of effort to collect the cases, no?